Hi, this is Ms. Back. Continuing on with Unit 12. This part is on rehabilitation. Most of this comes from Chapter 25 in your book, which overlaps a little bit of things that we talked about in the musculoskeletal system. But rehabilitation is to restore a person to their highest level of functioning. We use a holistic approach, which means to treat the whole person, mind, body, and spirit. Factors that affect progress and rehabilitation is how soon the rehab is begun, pre-existing diseases or injuries, overall motivation, type of facility, combined efforts of staff, family, and friends, attitude of the rehab team, consistency in the care plan. Rehabilitation team is made up of physicians. There are specialized physicians who specialize in rehab. They are called physiatrists. We have nurses, we have physical therapy, speech language pathologists, occupational therapy. So a lot of times when somebody is first admitted to a nursing home, they will PT, OT, and ST will all evaluate them and see what their needs are to develop their care plan. There's a social worker, there's discharge planners, nurse assistants, a family and friends, and the resident. The resident is the most important member, obviously. That needs to be resident-centered care. The care plan itself is based on goals for restoring and maintaining function. Okay, so rehab is somebody who you're wanting to, like they've had a stroke and you're wanting to get them back, close to where they were or maintain where they're at. And then could be post-surgery too. After knee surgery, they'll go to rehab. After hip surgery, they go to rehab. After stroke, they go to rehab. If rehab is not an option any longer, then it becomes restorative care. So restorative care, like I said, is ordered when rehab is no longer an option. It is to maintain them function. You don't want to them lose anything that they have, improve their quality of life, and increase their independence. Restorative care programs include elimination, range of motion, positioning, mobility and ambulation, transferring, grooming, eating, drinking, splints and braces, and communication. So we don't want them to, if they've had a stroke, sometimes communicating, want them to always be able to do as much of these things as they can. Promoting independence is encouraging independence has positive effects on self-image, attitude, and abilities. Residents should do as much as they can for themselves, regardless of how long it takes and how well it is done. Independence helps with self-esteem. It's a good thing to keep in your mind, to never do for somebody what they can do for themselves. That makes them kind of dependent on you. Although sometimes it's easier to do it for them, for their best interests, we let them do what they can do. Loss of function. Loss of functions due to illness or injury causes dependence on others for activities of daily living. This affects their self-esteem. So when they can no longer do something, it can cause anger, frustration, depression, and embarrassment. Range of motion. So we talked about that when we were doing the musculoskeletal system. This chapter just goes into it a little bit more. What you guys have to be checked on is that bottom one there, passive range of motion, is where it's somebody who is in bed and can't do it for themselves. It's done by the staff without any help. And then there is the top one there, active range of motion, AROM, which is done by the resident. You may just guide them and tell them, okay, we're going to do your shoulders, we're going to do your arms, but they do it. You don't touch them. And then active is when you are assisting them. They're done by the resident, but you're helping them. Know the following body movements: abduction, adduction, extension, flexion, dorsiflexion, plantar flexion, rotation, pronation, supination, opposition. That's very important to know those. I'm pretty sure on your test those are matching, so make sure you study those. And then, of course, also to be checked off on your passive range of motion. Those are the things you're going to be doing too. So make sure you can demonstrate and answer matching questions on that. Guidelines for range of motion. You follow the care plan carefully. Nurse assistants are not allowed to exercise the head and the neck. So you begin at the top of you start at the head and work your way down. So you would start with the shoulders. Nurse assistants would. Then you would do shoulders, elbows, wrists, fingers, and then hips, knees, ankles, toes. Support above and below the joint that is being exercised. Range of motion, you promptly stop if they are reporting pain or you meet resistance. You always want to keep the body in good alignment and exercise both sides of the body. Generally, we tell them to do 3 repetitions of each exercise. So if you were doing flexion and extension of the shoulder, you would do 3 flexion, 3 extension, and then move down to a different exercise. Use range of motion as an opportunity for communication. Hip abduction splint. We talked about that when we were talking about hip replacement, but just remember that's placed between the legs to immobilize and position the hips and lower extremities. Used most commonly after hip replacement because you don't want that hip joint to get dislodged. This is a picture of a contracture. This is permanent stiffening of a joint, and it is painful. So if they lay in bed and they don't do any range of motion exercises or any movement, this is what will happen. Their joints will kind of draw in like that. Sometimes you will see people use what's called a hand roll. That's just a washcloth in there to kind of prevent that from happening. There are actually more sophisticated types of hand rolls, but a washcloth will work in beginning stages if you start to notice somebody's hand drawing in. And atrophy is wasting away of muscle. They haven't been walking, they haven't been doing anything, so the muscle is just gone. It's just pretty much skin stretched over bone. Positioning devices. One commonly used is a footboard to prevent foot drop. Another thing that can happen is their feet will drop and then they won't come back up. So plantar flexion is when there's a range of motion exercise where you where you push the foot down, and so foot drop would be permanent plantar flexation where it doesn't come back up towards the body. It's almost laying flat, and that's what you would use a footboard for, to prevent foot drop or permanent plantar flexion. Canes, walkers, and crutches are considered walking aids or ambulatory devices. A cane, the main use is for balance. You would put the cane on your stronger side. A walker moves first, then the weak leg, then the strong leg. Walker has to be used by somebody who can do full weight bearing on both legs. Crutches are used for limited weight or no weight bearing on one leg. But in any case, canes, walkers, and crutches are specifically fitted to each resident. So there would be measurements that would be taken to make sure that they're fitted for one of your skills that you could do for clinical was ambulatory devices, and it goes into that better. It'd be a good one to watch along with this chapter. Elastic bandages. This was on your test, so I just wanted to talk about it. Their role is to keep dressings in place or hold splints in place. They provide protection, compression, and support, and they decrease swelling from injuries. Elastic bandages should be wrapped distal to proximal, and they should be smooth and wrinkle-free. So when I say distal to proximal, remember distal. When you think of distal and proximal, you're thinking of point of attachment. So that has to do with your extremities. Where does your arm attach? It attaches at your shoulder. So if the area is closer to your shoulder, it is proximal, And if it is a farther distance from your shoulder, then it is distal. So when you are wrapping a foot, you would start towards the toes and go up, distal to proximal. And that's all I have. Thank you.